Good evening, respected chairpersons. My talk will be on practical implications of hemodynamics before and after a BAV. So I'll be just focusing on what information you can get from pressure tracings about the during a procedure. Aortic stenosis, we all know, is the most prevalent aortic valve disease. 3 lakh people in the world have it, and prevalence increases with age. And the commonest we see is congenital bicuspid, calcific, and rheumatic. The recommendation, the aortic valve is not as friendly valve as mitral for an interventionist. It is a more surgical friendly valve. Reason being the restenosis rate is high and mortality is also high compared to balloon mitral valvotomy. So the recommendations for younger patients is good, like you have many class 1 and class 2 indications. In symptomatic patients, you can say if the gradient is more than 50, and in asymptomatic, if the gradient is more than 60 or ECG suggests ischemia, or the patient wishes to have pregnancy or to competitive sports, you can recommend balloon aortic valvotomy. But if you see for an adult patient, it is only as a bridge to serious event. Like it could be the patient is hemodynamically unstable, going for an AVR, or patient has serious comorbid conditions, or if he's going for a non-cardiac surgery, only then you do aortic valvuloplasty. So pediatric cardiologists are more experienced with balloon aortic valvuloplasty than adult interventionists. And the criteria for severe AS, I think you would have read all this in standard textbooks. And if you see as the aortic valve area decreases, the pressure gradient increases. And once the valve area reaches 1, after that it is vertical takeoff for the pressure gradient and for the patient also. But that gradient is just a 1-beat gradient. Or you can measure the one catheter inside the LV, and you can use the side port of the femoral sheath, which is not a right way to do. I will be telling about later. Ideal would be to do a double puncture and simultaneously measure the LV and aorta beat to beat. And nowadays you have catheters like pigtail with double Newman catheter, where a single pigtail catheter can measure pressures both in the LV and aorta. And or you can even use a pressure wire through a pigtail, of course, which is very expensive, and transeptal is not ideally indicated. So when we compare the pressure gradients from Doppler velocity and cardiac catheterization, the values which we measure in the cath lab peak to peak gradient will be lesser than the peak instantaneous gradient measured by the cath lab. So before starting to measure pressures, one should check for over-damping, under-damping, or weak artifact, and always rebalance your zeros before starting to take pressures. So this is through your single arterial axis. If you pull back from the, LV to aorta, you can see the gradient between the LV and aorta. This cannot be applied when the heart rate is fast or patient is in atrial fibrillation. And never use simultaneous aorta and femoral artery pressure, because as you can see, the femoral artery, the distal pressures as you go is wider, the pulse pressure is wider, and so you will falsely underestimate the aortic stenosis. Similarly, if you have stenosis in the iliacs, then the pressure will be, amplitude will be smaller, and you can overestimate the gradient. So never use a central ascending aorta and a femoral artery pressure. Always use the central ascending aorta and LV pressures. And now you have this multi-track catheter, which also can be used to measure the gradient with a single axis. When you take a double axis from both sides and then measure the gradients, that will be the ideal to measure the mean gradient in the cath lab. Never use end-hole catheter, because damping can occur with end-hole catheters. You can see on the right side, when you are using an end-hole catheter, the amplitude of the aorta is small, and hence you will be overestimating the gradient. But whereas when it is not occurring, the gradient will be lesser. So always use side-hole catheters. And the catheter positions also should be proper. If you see in this previous, the first pressure tracing, it shows marked delay in fall of the pressure during early diastole due to fusion of LV and aortic pressure. This is because the pigtail is partially inside the LV and partially in the aortic valve. So one should push the, once you push the pigtail properly, you get the proper tracing like this. With the hemodynamic tracings, you can also know the level of obstruction. Your aortic valve stenosis could be valvular, supravalvular, or subvalvular. If you see in supravalvular, after pulling out from the LV, the initial portion of the aorta shows a hybrid form of wave which resembles more like the aorta. Whereas in a subvalvular, if you see, the hybrid wave resembles more like an LV because this is in the LV and this is in the aorta. So this tells you that this is a supravalvular obstruction and this is a subvalvular obstruction. Then you can also detect whether the obstruction is fixed or dynamic based on the pressure tracing. If you see here in the fixed obstruction, you will have low amplitude, slow rising, late peaking aortic pressure. And you can see the LV also peaks earlier. But whereas in a dynamic obstruction, you can see early peaking, you can see the spike and dome pattern, and you can see the late peaking of the LV. All this tells you that this is fixed obstruction and the other is dynamic obstruction. A response to a VPC also helps you to differentiate from a fixed and dynamic obstruction. If you see in a fixed obstruction, post VPC, there is an increase in the pulse pressure, but whereas in a fixed in a dynamic obstruction, there is a fall in the pulse pressure. I mean, I didn't know that there was a subsequent topic about Hocum, so I don't want to invade into his territory. I think he'll be talking about Brocken-Brodel sign. And another thing one should note is, if the aortic stenosis is very severe and the aortic valve area is less than 0.6 centimeter, and then when you pull out the pigtail while from the LV into the aorta, there will be a rise in the pressure by more than 5 millimeters of mercury. You can see from here, when it's pulled out, there is an increase in 5 millimeters of mercury. This is a Caraballo sign indicating that the patient has valve area of less than 0.6 centimeters square. And in these patients, you should not use higher French catheters to be, you should use a smaller 4 French pigtail to measure the gradient. So this is the pre-BAV. You can see the gradients, and then this is post-BAV. This is what you ideally expect after the procedure, but you may not see that. And instead, if you see this, you know that you have torn the wall and patient has developed aortic regurgitation. And if you, with this, you can even tell whether the aortic regurgitation is mild, moderate, or severe. And acute aortic regurgitation, patient presents with dramatically with hypotension and pulmonary edema. The LV EDP increases markedly, and because the LV has no time to respond, and there is absent wide pressure, wide pulse pressure, which we normally see in a chronic aortic regurgitation. And at that time, you can do an angiography, and based on the angiographic grade, you can know how severe the aortic regurgitation is. Calculation of aortic valve, the next after the gradient, why you should calculate the aortic valve area. Based on the gradient and the aortic valve area, then you can decide what are you going to plan. In the cath lab, the calculation of aortic valve area is traditionally performed using the Gorlin's formula, for which you need cardiac output, heart rate, systolic ejection period, and the mean transvalvular gradient. Usually you can do it by the fixed method or the thermo indicator dilution method. In low output states, it's better not to use the thermo. And cardiac output, we usually use, we don't use the oxygen consumption by the metabolic Hood or Douglas bag method because it is cumbersome. And we are just imagining the arteriovenous oxygen difference, the oxygen consumption, which can have an error of 30 to 40%. And you have an alternative Hucke formula where also you can calculate the aortic valve area, where the cardiac output is divided by the root square of the peak and LV and aortic pressures. And one should also remember the pressure recovery phenomena. What happens is the pressure energy proximal to the stenosed aortic valve gets converted into kinetic energy immediately after the valve, and then again gets converted into pressure energy. Because of this conversion of pressure energy to kinetic energy, at this vena contracta, you will have the lowest pressures. If you take the pressures a little above, you will get the true gradient. Here it will be a low gradient. So one should remember this pressure recovery phenomena both in the cath lab and in the echocardiographic lab. CT also has a role just like you calculate calcium score for coronaries, even for aortic valve, you can calculate the calcium score, and if the calcium score is more than 1650 units, it indicates severe AS, and the specificity is more than 80%. And this is also useful in identifying in low flow, low gradient aortic stenosis. So based on the different types of aortic stenosis are, you can have normal ejection fraction, normal flow, high gradient AS, or you can have low flow, low gradient with normal LVF, and low flow, low gradient with low EF. So this, the first condition is straightforward, which forms 50 to 70% of the patients, and you can send the patient to for surgery. And now for this low flow, low gradient AS, also you have a method to identify whether it is really true severe AS or pseudo AS, and then you can plan accordingly. It is this third which we have found out only in the late 2007s, where the ejection fraction is normal, but you have a low flow, low gradient because of impaired diastolic function. This is more like your impaired diastolic dysfunction, where you have a normal LV function but impaired presenting with heart failure. It is those kind of groups comes under this. So what you do is do a dobutamine stress echo when you have low flow, low gradient with LV dysfunction, and then in the dobutamine stress echo, if your stroke volume increases by more than 20%, that means you have LV flow reserve. If it doesn't, if the stroke volume increase is less than 20%, then you don't have no LV flow reserve. This forms 30 to 40% of this group of patients, and this forms 60 to 70%. If you have a LV flow reserve, then you calculate the mean gradient, then you calculate the effective orifice area. This is projected effective orifice area. There is a new method whereby if the flow is considered fixed, and then what would be the aortic valve area. With that also you can calculate, and then you do a CT calcium scoring. So based on these values, if the effective orifice area is less than 1.2, then it is true severe AS, then you send the patient for a surgical aortic valve replacement plus minus CABG. And if the effective orifice area is more than 1.2 centimeter, then it is pseudo severe AS, and this patient is better off on medical treatment. So how to differentiate this true severe AS from pseudo AS? You will have to do the dobutamine or nitroprusside test. So patients with true severe AS manifest with the contractile reserve, that is the stroke volume increases by 25%. In contrast with pseudo AS, will have no contractile reserve, and they will not show any increase in their LV aortic pressure gradient. So this is a patient who had a baseline gradient of 28 millimeters with an aortic valve area of 0.7. After dobutamine infusion, the gradient increased to 42, and the aortic valve remains the same. So this patient has a true severe AS. And the other side, you can see the gradient is 22, aortic valve area 0.7. After dobutamine, the gradient increases to only minimally 24, but the aortic valve area is 1.0. So this is pseudo AS, and this patient can be left on medical management. Thank you.